Hi, all. Welcome back. Last time out, we were talking a little bit about pressure. We're talking about the SA, the AV nodes, kind of the electrical impulses that are controlling the heart. Now, I kind of want to talk about what controls the SA and the AV nodes, and then get into some complications with different conditions that can occur either in the veins or the arteries, and so forth. All right, so last time out, we're talking about the cardiac center, and we're talking about the SA node and how it's a pacemaker and how it controls the heart rate, and it's sending that signal from the SA node. It's sending that electrical impulse to the atria cells, and it's going from the right and the left are kind of firing in unison, and then it sends that electrical signal to the AV node, and then the AV sends it down the AV bunch or branch, and then down into the right and left branches, bundle branches. Okay, I mentioned this a little bit before. Okay, but the AV node is the SA node is a pacemaker. So it already has a distinct heart rate at about 100 beats per minute. Okay? Any deviation from that is often associated with the sympathetic or parasympathetic fibers that might affect the SA node. So things that can change that are things like body temperature, physical exercise, fight or flight response, okay, the amount of sodium, potassium, calcium you have in the system, lots of these things. The amount of adrenaline that's in the system, norepinephrine that's in the system. So there's a lot of hormone changes that can alter heart rate. Again, it's a pacemaker, but it can be altered by the condition of the body. This is a good thing, and I mean, from a evolutionary perspective, this allows the heart to pump more blood faster to regions that need it when maybe higher metabolic rates are needed in that region. If you need to run, you need to increase your heart rate, push more blood to that region, so the mitochondria in those muscle cells can go through cellular respiration faster, and it's not an oxygen limitation that's occurring there. Maybe it's a glucose limitation, but nonetheless, it's not an oxygen limitation that's occurring in the leg muscles, and you're able to run and keep up that metabolic rate for longer periods of time. If you need to shut it down and relax the parasympathetic fibers, okay, so if you're sleeping, if you're resting, okay, it can slow that heart rate down so it doesn't have to push blood as fast. So it can conserve energy, and the mitochondria are not burning as fast, and whatnot. So same thing with body temperature. If it's really cold out, okay, or really hot out, okay, there's different ways of which the sympathetic and parasympathetic can react to that. Okay, so the parasympathetic, again, this is reaching the heart via the vagus nerve. Okay, and like I said before, the SA node rate is about 100 beats per minute. Okay, this is really innately controlled. It's genetically controlled. Some individuals may have a little bit higher beats per minute or a little bit less beats per minute. Okay, and then any deviation that lowers it is normally the result of the parasympathetic system. So it might lower it to 60 to 80 beats per minute. Okay, so that will decrease the heart rate, and that's because it's influencing the SA node, which then influences the AV node, and really it also influences the AV node directly. The sympathetic impulse, again, this is your fight or flight response. Okay, it has accelerator nerves. Okay, which means that it's going to increase the heart rate, and that is going to in turn increase the impulse from the atrial to ventricular myocardium. In response to all of this is the baroreceptors that occur in different regions of the cardiac cycle or cardiac system. Okay, so you have baroreceptors that occur in the pulmonary artery, and you have baroreceptors that occur in the stem of the aorta, and these are pressure receptors, which basically they're measuring or reacting to the stretch of the wall of arteries and vessels. So if those arteries or vessels are really stretched, it indicates high pressure, and it will send a signal to potentially lower the heart rate, or increase the heart rate. It just depends on what's going on. This is controlled by the medulla oblongata. So you have a cardiac control center in the medulla oblongata, okay, and it's really related to both cardio inhibitor reflex center and the cardio accelerator reflex center. So both, it can speed up the heart or relax the heart, or basically slow the heart down. And that's based on the pressure that is being sent back from these baroreceptors that are occurring in different places in the heart. So let's look at kind of how this goes. So you have a receptor. Let's say we look at this carotid baroreceptor. So in the carotid artery, you have a baroreceptor that's measuring basically the stretch of that carotid artery. Okay? If it's stretching a lot, it's going to send that signal, okay, that the pressure is increased here. Okay? That's going to send a response from the medulla oblongata back to the SA and AV node. Okay? Same thing though. You can get similar responses in what's going on in the aortic baroreceptor. Okay, so if the arch of the aorta, if there's a lot of pressure coming out of it, so the ventricle is sending a highly pressurized fluid, okay, it's going to stretch that receptor again, send the signal. Other things that are going on, you're getting signals, you're getting impulses from the frontal section of the cerebrum, you're getting impulses that are sent down the spinal cord to the veins that are occurring in different regions, okay, all of which may be increasing, slowing down the impulses to the heart, controlling the heart. So there's lots of things, and this is just looking at the baroreceptors and how pressure might change it. Okay? In addition to that, you have hormones that affect these. In addition to that, you have blood chemistry that might affect this. So the control system, sometimes you can be sending mixed signals, and we'll kind of talk about how that works in a little bit. Okay, so from a clinical application, a lot of times what we will see with individuals at different times, especially if they're coming into a hospital or clinic, etc., for cardiac symptoms or issues, is arrhythmias. Okay, so these are going to be some type of altered heart rhythm. And different arrhythmias have different causes. And so we're going to kind of cover some of the arrhythmias that would occur or are more prevalent in many societies. So the first one is fibrillation, okay, or the uncoordinated contraction of myocardium. Okay, so you can have atrial fibrillation, okay, which means the atrium is not coordinated. So maybe the right is contracting and then the left is contracting. So they're not in unison. Okay. And then you can have ventricle fibrillation where, maybe the left and the right are not firing at the same time in unison. Okay. The atrial fibrillation is not life-threatening typically. It can cause complications, okay, but the ventricular fibrillation is often fatal, okay, because what happens is there's not enough force, okay, to send blood out of the heart. Okay, so this is really, ventricular contractions is really based on a lot of force that's building up. And so if the ventricles are firing off unison, okay, there's not enough force to force the blood out the aorta or out the pulmonary trunk. Tachycardia, we've talked about it in class quite a bit. That's an abnormal heartbeat, okay, so greater than 100 beats per minute. Bradycardia is an abnormal slower heartbeat, okay, less than 60 beats per minute. Okay. A flutter typically means that there's normal beats and then you might have two contractions that happen back to back. Okay, and so you get normal regular contractions and then a flutter, which would be kind of a rapid inset of a contraction. Okay. Premature beats, again, similar to flutters, except for it would just often originate kind of not associated with the SA node. Okay, and we'll look at these. Some of these are hard to distinguish whether it's a flutter or premature beat, things like that. An echotopic pacemaker would be basically a secondary pacemaker. The AV node is taking over, so the SA node may not be stimulating enough, so you have the AV node which is now controlling the system, okay, which would then change the heart rate of the individual. Okay, so we do have a backup system in our heart. So the SA node is the main pacemaker, but the AV node can take over if there's something wrong with the SA node, okay, which would often mean that, remember when we were talking about the atrial to ventricle fill, if the atria is not firing, if the atria is not contracting, 70% of the blood is going into the ventricles. It may take a little bit longer for the pressure to build up before the cuspid valves, the atrioventricular valves, close, and then the ventricle can fire through an AV stimulation. Okay, so you might get less blood flow, your blood pressure might be a lot less, and often you get heart rate that differs. Okay, artificial pacemaker. Okay, we've talked about these. I showed you one in lab. Okay, this is just a device that can control for maybe a faulty SA or AV node, or maybe they're both faulty, and often it's just a battery powered electrical impulse that just sends a electrical impulse at basically 100 beats per minute. So let's look at a couple examples of these. So first, let's look at this one. Okay, this is an example of, ventricular fibrillation. Okay, so you can see that the ventricles, your QRS, they're not there. So you get maybe a P wave and you get a little bounce, maybe another P wave. You just can't distinguish the ventricle is not, it's not contracting at the same rate. So the left and the right are not contracting in unison, so you don't get these nice QRS waves, and it's very messy, very dangerous, can result in death for sure. What about this one? Okay, you see nice QRSs, but they're happening at a much faster rate than you would expect. Okay, that's tachycardia. Okay, this one here, okay, if that's tachycardia, these are much more what we normally would call the R to R, the amount of time between R and R, okay, that rate would tell you whether you're in tachycardia or bradycardia. Okay, so these are slow. Heart beats look good. Okay, they're PQRS, T. So the actual heart looks good. It's just the rate between beats is slow, is fast. Okay, and then you notice here you have that PQRS and then PQRS and then another one right afterwards. That's a flutter. Okay, and so in this case you have lots of P waves that are happening, so it's like you're getting continuous stimulation that's occurring, but that can cause a QRS or the ventricle to fire prematurely or have a very long period where it's not firing. Okay, and often that's exactly what's going on. You're going into an arrhythmia, a irregular heartbeat, because you're getting stimulation that's happening constantly, and it's building up, and then you can get a premature ventricle systole, or you get a delayed ventricle systole. All right, let's jump to blood vessels real quick. Hey, most of this is going to be kind of review because we've dealt with it in the lab quite a bit. Blood vessels, these are the tubes, these are the organs that transport blood from heart to body cells, back to heart, etc. Closed circuit system, and it's made of two main blood vessel types. You have arteries, which carry blood away from the heart, and then you have veins, which carry blood to the heart. Now you have different kind of renditions or intermediates of these. Arteries have arterioles. Okay? These are smaller arteries that are receiving blood from the artery, and they carry it to the capillaries. So this is the connection to the capillary is arterioles. Capillaries is the site of exchange between arterioles and venules. Okay? And so that's where really the blood is transferring what it needs to transfer to the cells. Okay, and so often this is an oxygen transfer and a carbon dioxide or waste product transfer, but also many other things, nutrients, sugars, ions can be transferred, other waste products besides carbon dioxide like nitrogen, okay, ammonia, these kind of things are picked up. Okay, so the connection between arteries and veins are capillaries. Okay, they just happen to have intermediates, the arterioles, the venules, and then the veins are carrying that blood that's often less rich in oxygen, more rich in carbon dioxide. It's carrying it back to the heart. Okay, so a couple ways at which we can talk about blood vessels. And one of the things that's kind of important is when there's damage to tissue, often there's damage to blood vessels in that region. okay, which means that the blood vessels need to regenerate. Okay, and they do so by VEGF, or vascular endothelial growth factor. Okay? And this is what stimulates the new formation of blood vessels, whether that be arteries, arterioles, venules, veins, new capillary beds, that connection between them. Okay, and often that is just associated with damage. It's associated with um, disease can deteriorate blood vessels. Old age can deteriorate blood vessels. You can get blood vessels that are deteriorated because of a clot, because of a blockage, lots of things. And so, what determines whether or not we have the ability to lay it down? Of course, the same things that would determine if we have the ability to heal the wound in the first place, and that is, do you have enough nutrients, do you have enough cells in the region, etc. So promoting it could be all kinds of things. So you have a blockage in the coronary artery. Okay, the body would secrete VEGFs, and we, from a science perspective, by combining it with technology, we know individuals that have had heart attacks or major damage to blood vessels, etc., they might not secrete enough VEGF. So we've been trying to devise ways at which we can transplant or have VEGF be delivered to regions that need to grow new blood vessels, but not so fast that the blood vessels become damaging. So you have to have a time release capsule. So it's a slow release. Gene therapy is playing a big role in this, because sometimes VEGF or lack of it is due to mutations. So there's lots of situations here. Sometimes we want to prevent it, though, because when you develop cancerous tumors, they are stimulating VEGF because the tumor itself needs blood flow. It needs the nutrients. It needs the oxygen. Remember, tumor is just uncontrolled cell growth. And so it needs nutrients and oxygen, and needs to take waste products away so it can keep dividing. And so it keeps secreting VEGF. So we use anti-VEGF drugs, or anti-angiogenesis drugs, to treat cancer and other age-related mutations that might be causing lots of veins to be laid down in regions that we don't need them. Right? Now, something that is kind of important that a lot of students don't realize is, yes, the importance of things like arteries. We know that arteries are carrying high pressured blood away from the heart. The heart's very important. The lungs are very important. But in the grand scheme of things, these places in your body have very little blood compared to veins. Okay, so veins are where the majority of the blood is actually stored and would be found, okay, traveling through the veins of the body. So about 2/3 of the blood of the body is found in veins and venules at any given time. So even though these other regions are really important for the functionality of the cardiovascular system, okay, when we're talking about overall control of the majority of your blood in the body, it's the veins and venules that are controlling it and housing it. That's important because a lot of ailments that happen to individuals are due to the pooling of blood in the veins. Okay, so blood vessel disorders, okay? Arteriosclerosis, okay? This is when you have plaque, cholesterol plaque that's developing or lining the arteries and arterioles of the body. Okay, again, we've talked about this before. If you have a thinning, or if you have less of a gap for blood to move through, and maybe you have high platelet counts, or maybe you have other high levels of cholesterol that's moving through the blood. Maybe you have lots of sugars. So maybe you're diabetic and you have high levels of glucose in the system, which is making the blood more viscous, and you have these plaques forming, which is decreasing the diameter of your arteries. Okay, then you can get a clot to form, you can get a blockage to form, which can cause major damage. It can cause the aneurysm to occur. And that's when the artery wall will be dilated. Normally, when it's dilated, it weakens and may burst. Okay, and if it bursts, then you have internal bleeding, a major problem. Okay, so the aneurysm is the bulge in the artery. Often it's related to having kind of a smaller diameter and then a blockage form, and there's no place for that blood to go because it's pressurized, so it just pushes out on the wall of an artery, and if it's weakened there, it could burst. Phlebitis, okay, is inflammation of a vein. Often this occurs in the legs, and it is a common disorder, but it can be extremely dangerous, especially if it's deep phlebitis, which can be associated with clotting, and so it can be a very dangerous disorder, even though it's really common. Varicose veins happens a lot to people as they age, and it's a lot like kind of an aneurysm, in the sense you get this dilation because of pooling of blood. But remember, it's not under the same kind of pressure that an aneurysm is. Instead, it's less pressure, more the pooling, which will cause it to dilate and damage the veins. So they're not as linear, they're not as smooth, and often this occurs in legs, and this can be the result of many different things. You could have major muscle damage, which causes varicose veins. You could have broken bone that's known to cause varicose veins. Surgery on individuals that known to cause varicose veins. Just individuals that stand for too long. So if you spend long hours standing, nurses, watch out for this. Okay, varicose veins, same thing. Like, it's just a pooling of blood that often will happen because the contraction of the muscle is not forcing the blood back to the heart. Instead, it's allowing the blood to pool in the veins, and then that causes damage to the structure of the vein. Okay, so this, you can just see some of that arteriosclerotic plaque that's forming. So a normal kind of clean, still going to have a little bit of plaque buildup, just natural, because that's kind of a natural coating that protects the inside of arteries. Okay? But when you start building that cholesterol up, that layer of protection starts building up more and more. And so there you can see a fairly thick plaque layer. Decreases the diameter at which the blood can flow through. That's called the lumen. That open space is where the blood can travel through. And so when you get these increases in plaque, you can have clots form, or you can have thrombocytes bind to that plaque on the inside, and then you can get a clot forming behind it. And when it gets really severe, the lumen is very small, and then it doesn't take much of a clot to form, and you can get an aneurysm that forms behind that. Okay, so really thick plaque layers over long periods of time can be extremely dangerous. And so, in some cases, when this occurs, maybe stents are put in, okay, which would open up the lumen area to allow for more blood flow to come through. But this is why a lot of older people who have plaque in their arteries, not just older people, but that's why they're often on blood thinners, is to ensure that the blood can make it through the limited space in the lumen. Okay, low cholesterol, blood thinner diet kind of thing, so the blood can travel through that lumen. All right.